in adults in residents who underwent many various training programs. So the optimal management of both conditions, I mean sarcopenia and osteosarcopenia, is a serious challenge for geriatric and rehabilitation medicine, and may be focused at designing a multimodal exercise-based programs in the future, which will incorporate traditional and high-intensity resistant training modalities, weight-bearing exercises, and balanced mobility activities. Finally, I would like to conclude my welcome speech inviting you to participate in establishment of an international sarcopenia and osteosarcopenia network, as well as to encourage you to elaborate new guidelines for management of both musculoskeletal conditions. Last but not least, I would like to thank you, all the delegates, all of you, all the participants in this webinar, the rector of the Medical University of Sofia, the deans, and the ex-dean, the Professor Vodeničarov, a brave man who introduced the term of public health in health management in Bulgarian medical education, as well as in Bulgarian healthcare system. I wish you everyone a successful and fruitful webinar. Thank you, dear friends. Thank you, dear colleagues.
Thank you, Professor Papathanasiou, for this nice introduction and the comprehensive welcome. And I believe it's now my turn to welcome you on behalf of Professor Mark-Ali Alexander, the founder of Sustain Our Abilities. Just 2 words about Sustain Our Abilities, that rehabilitation education should be available for everyone around the world. That's the main message right now from Sustain Our Abilities. And after this message, I would like to go forward in the first session. We are waiting for some panelists for the welcomes. Professor Karolina Lyubomirova, the Vice Rector of Medical University of Sofia, and Professor Krasimir Vitsev, the Vice Dean of the Faculty of Public Health of University of Sofia. However, we need to proceed with the first presentation and the first session. And I will ask on the floor the chairpersons, Yannis Papathanasiou, the Professor Yannis Papathanasiou, to join me in this first session and present Professor Andrea Meyer. Professor Papathanasiou. Can you hear me, please? Professor Papathanasiou?
Yes, I'm hearing you.
Yes.
Thank you very much.
Would you like to present Professor Andrea Meyer?
Professor Andrea Meyer is a gerontologist and geriatrician and health policy planning specialist in Australia, Singapore, and Netherlands. She is a researcher focused on unraveling the mechanisms of aging and the interaction of aging and age-related diseases. During the last 10 years, she has conducted multiple European observational and clinical trial studies, and she has published 290 peer-reviewed articles, achieving a Hirsch index of 49, spearheading the significant contribution of her highly acclaimed, innovative, and global multidisciplinary age research group. She is a frequent guest on radio and television programs to disseminate aging research and an invited member of several international academic and health policy committees. Currently, she's a president of the Australian and New Zealand Society for Sarcopenia and Frailty Research. Dear Professor Meyer, we will be grateful to hear you.
Okay, and now before that, I will ask my colleague, my co-moderator, Adonis Kotaxakis, to please put the video from the presentation from Professor Meyer. Thank you, Adonis.
Symposium about sarcopenia. Welcome to this international symposium about sarcopenia. I'm Andrea Meyer. I am by training a geriatrician and internal medicine specialist and a professor of aging at the Vrije Universiteit Amsterdam in the Netherlands and the University of Melbourne in Australia. And currently I'm the president of the Australian and New Zealand Society for Sarcopenia and Frailty Research. Therewith, sarcopenia is dear to my heart, and today I will talk about definitions, assessment, and therapy. You might know that it's a beautiful organ, the muscles. It's not only relevant for contraction and there was movement, standing, sitting, lying, but also it's an important organ for glucose metabolism and protein storage. And most beautifully, it is because it's a modifiable organ, which means if we are very sedentary, we will lose muscle mass. And if we go to the gym, we can gain muscle mass. What is occurring during aging? Muscle mass is declining during age. There was also muscle strength and physical function. You see a very representative picture of a 20 and a 60-year-old with a CT scan of depicting the leg muscles, and what you can see with the chronological age that there is more fat mass and less muscle mass, and there's fat infiltration between the muscles, and also on cellular level we see fat infiltration within the muscle cells. And of course you might notice then if there is lots of fat infiltration that the function of the muscle is being worse. What is occurring, this is muscle mass, what is occurring with age in terms of muscle strength? You see the trajectory. We analyzed around about 200,000 individuals, and what you can see at the age of 20 to 50, muscle strength measured by the handheld dynamometer, the hand grip strength is declining, and then there is a change point at the age of around about 50 where muscle strength is more rapidly declining with age. I'm a physician working most of the times in the hospital, so I'm quite interested what physical inactivity is doing with our muscles in humans. And you might already know that inactivity in bed rest is really detrimental to our muscles. There are studies showing that if you have healthy older adults in bed rest, that within around about 10 days, they can lose up to 10% of their lean mass of their muscles. There we looked at, okay, these are healthy individuals, what does occur during hospitalization? And we did a meta-analysis, and what we actually showed is that in individuals who are electively admitted to the hospital, that these individuals decline in their hand grip strengths and their muscle strengths over time during hospitalization. However, if individuals are acutely admitted to the hospital, there is no change in hand grip strengths. But for electively admitted individuals, there is an absolute decline in hand grip strengths. If we are looking at muscle mass, you see the following. First of all, there are not many studies looking at muscle mass, but during hospitalization, there is a significant decline of muscle mass in electively admitted individuals, patients, and there is towards a trend, but very, very tiny numbers of patients being included of the change of muscle mass in acutely admitted individuals. What is the prevalence of sarcopenia really? Before going into detail how to diagnose and define sarcopenia, it's very, very prevalent. Around about 10 to 15% of the general population has sarcopenia. 30% of inpatients have sarcopenia, and 50% of patients in rehabilitation and nursing homes have sarcopenia. And it's a highly prevalent disease in individuals with already another disease. So we have looked at the prevalence of sarcopenia as a comorbid disease. So comorbidity is the state when you already have one disease and you get another. So for example, you have a cardiovascular disease, then it's very likely that the prevalence is 33% for sarcopenia. If somebody has dementia, you see in the red aligned numbers, it's around about 25%. If somebody has diabetes, it's around about 20%. If somebody has respiratory diseases, it's 25%. So in the general population, as said, it's around about 10 to 15. However, if in the general population somebody already has another disease, like as diabetes or respiratory diseases, dementia, cardiovascular disease, then the prevalence really jumps to 22 to even 30%. It's highly prevalent. Is it a disease which is relevant? I would say yes, absolutely. We have shown that sarcopenia is associated with falls in individuals. Here you see all studies who looked at sarcopenia independent of the definitions being used in falls. And what you can see is that there is an odds ratio of 1.64, which means that if somebody has sarcopenia, there is a higher chance of 64% of having a fall compared to the one who has no sarcopenia. And it's also associated with fractures. Around about the same effect size, 73% more risk if somebody has sarcopenia to have a fracture compared to the one who has no sarcopenia. And of course, then it's also relevant to look at other outcome parameters such as mortality. Here you see the odds ratios and hazard ratios for mortality, and what you can see, all the diamonds are to the right from the reference 1. Which means there is a higher risk of mortality of around about 1.5 to up to 2.5 of the hazard ratio to die in individuals who have sarcopenia compared to individuals who do not have sarcopenia. So sarcopenia is quite a relevant disease, and why I'm allowed to say sarcopenia is a disease, because since October 2016, we have an ICD-10 code. The code is M62.84. And while having an ICD-10 code, which is the International Classification of Diseases, sarcopenia is therewith a disease. Therewith, we can also treat it as clinicians. You might have heard already, because you're interested in sarcopenia, but what we wanted to know, what is the knowledge about sarcopenia among healthcare professionals. So what we did already a couple of years ago, we looked at the knowledge about sarcopenia and the availability of diagnostic equipment. And we wanted to know, okay, is it actually implemented that patients are going to be diagnosed for sarcopenia? Yes and no. And what we found is that there's a lack of knowledge and there is a lack of availability of diagnostic equipment. And therewith, sarcopenia is really not diagnosed in clinical practice, and therewith not intervened, which is a pity, I would say. A couple of years later, in 2018, that was in the Netherlands, and we also did the same survey in Australia and New Zealand to actually see if it's a worldwide problem. And the results were nearly the same. Also, there is a current knowledge gap in Australia and New Zealand, and so therewith sarcopenia is not being diagnosed and not treated. The question is always, if healthcare professionals don't know it, do patients want to be diagnosed? Therewith, we also surveyed individuals, older individuals in the community, what their knowledge is, and actually they also had no clue or didn't know what sarcopenia is. However, after giving a lecture and really showing the details about sarcopenia and being tested for sarcopenia, most of them were very, very willing to start interventions to counteract sarcopenia. So the knowledge, there is absolutely a gap. However, there is a willingness to be intervened. So what you do in clinical practice, can you diagnose sarcopenia just by looking at people? And of course, everybody will say, okay, the right individual, they might be quite healthy, and the left lady might be quite sarcopenic because that's a more skinny person. So can we actually look at individuals and look at their muscle state? No, we can. So this is not good, just looking to diagnose sarcopenia. What is also insufficient are these measurements. Weight is not giving you the clue what the body composition is. Hip circumference, waist circumference, all are quite bad measures. And also trying to estimate the fat in the body is also no good. Doing that subjectively and not objectively. So what are good measures? Here is a summary. To measure muscle mass, it's good to have a DEXA or a BIA or MRI scan or a CT scan. Of course, there always comes the question of availability. On the right-hand side, there is a handheld dynamometer, and there's a quadriceps chair as examples how to measure muscle strength. And especially the handheld dynamometer is very, very easy to implement in clinical practice. There are definitions how to diagnose sarcopenia, and I would like to start introducing the first European definition of sarcopenia. And what you can actually see is first, gait speed should be measured. For example, 4-meter gait speed. And depending on that gait speed with a cutoff of 0.8, hand grip strength should be measured with cutoffs of 20 and 30 kilograms, so 20 for females and 30 for males. And then depending on that, either there's no sarcopenia or there's low hand grip strength, and muscle mass should be measured. In muscle mass, we in clinical practice use the BIA, because we are measuring it in every patient. However, if you have the ability of the DEXA, that's even better. And MRI and CT scans are not very often used. This definition has been revised, and there was a release of the European definition 2, which is being used in the European countries. However, in Australia, we still use the first European definition. And what is the sarcopenia 2 definition? How different is it and what does it add? It adds the case funding by using a SARC-F. That's a screening tool for sarcopenia, a couple of questions. And if that screening tool is negative, there is no sarcopenia, and screening later, it's said. If the SARC-F is positive, abnormal, then the measurement of muscle strength, for example, the hand grip strength or the chair stand test. And then if that's low and abnormal, there's sarcopenia probable. And then there is the muscle quality or quantity should be measured, for example, with the DEXA BIA. Sarcopenia is then confirmed. And to separate sarcopenia confirmed to sarcopenia severe, the physical performance should be measured. So you see that muscle strength is really prominent here and quite easy to implement in clinical practice. After you diagnosed sarcopenia and before you treat, I would suggest to actually look at why muscle health is no good, because it can be different reasons. And of course, muscle mass is low. So it's something about muscle, but we shouldn't forget that we have the brain, and the brain is necessary to stimulate the muscles to be active. We need the lungs and the heart for perfusion with blood, and we of course also need the joint. If none of the systems is working well, of course there is a high chance of sarcopenia, but if one is failing, then also there might be a relation with sarcopenia. So take that into account. Always look at other systems which might interfere with muscle health and there with mobility. How can we intervene? Of course, physical activity is the most important one, and a diet is very important, especially protein intake. So if we diagnosed sarcopenia and we know what's going on, either there is a low physical activity or there is a protein deficits, then we are going to the interventions of sarcopenia. And most important is to recognize that we can either with resistance exercise training, a little bit also with endurance training and balance training, either prevent sarcopenia or train the muscles to treat sarcopenia. Most important, as given here, is really preventing inactivity, because inactivity is going to accelerate the muscle mass decline. So resistance training is the training to get muscles growing. And there is lots of evidence that actually resistance exercise training and the interventions will lead to a higher absolute muscle mass of the lower body and the upper body, and also that resistance exercise training gives much more hand grip strength, and also it changes and improves the gait speed, which is very nice. So what kind of resistance exercise training should you give? Progressive, very important, and high intensity. 8 to 10 different muscle groups. And high intensity, just to remind you, is 80% of 1 RM. So very important to have high intensity. The frequency is variable, but around about 3 times a week or even more, and always 10 repetitions in one set, and between some rest. Most importantly, I think what we don't do quite well sometimes in geriatric here is not forget the high intensity. What about diet? So protein, and amino acids is important, but also don't forget vitamins, for example, vitamin D. And again, prevention is the key. So prevent a catabolic state, because if the body is hungry, then muscles will lose their power and their mass. What kind of nutritional intervention is going to work to increase muscle mass? Especially the supplementation of amino acids, but also creatine has been proven to be effective, and proteins with energy in different in different groupings. So amino acids with protein, without, but most important is to give at least high protein supplementations to be able to grow the muscle mass. Where to get the protein, of how much protein? Around about 1.2 to 1.5 gram per kilogram body weight, which means around about 25 grams of proteins per meal. And as said, calcium, vitamin D is also very important. And if you prescribe physical exercise, don't forget the energy, because you need actually the energy to be able to also move the body. And of course, you might now ask, okay, how to get the protein into, if somebody doesn't want to get a supplement, into the diet. Here you can see a couple of examples, how much protein in grams is in a serving of food. Milk, for example, 8 grams of protein, yogurt, 5. Then you see in food, for example, 50 grams of tofu, 4. Very nice to do is an egg. An egg has 7 grams of protein, and you see further the list. Of course, also chicken and fish, pork has lots of protein and can serve as the source of protein for the supplementation for older adults with sarcopenia. So plenty of options. So next to resistance exercise training and the supplementation either with food or with supplements, there are lots of studies ongoing in phase 2 and 3 trials to actually look if we can stimulate muscle by giving medication, and thereby grow muscle mass. However, that's not yet implemented in clinical practice. We summarized the diagnostics and the intervention on a very little tiny pocket card. So if you're interested, please be in contact with me to actually see how to diagnose sarcopenia. We have it for the first and the second European definition, this pocket card, and how to manage sarcopenia. So please be in contact, and thank you very much for listening. Here you see my email address. Thank you.
Thank you very much, Andrea. I give the Professor Lubomirova to tell a few words.
Dear Professor Papatanasiou, dear colleagues and participants in this extremely important and interesting webinar, it is my pleasure and honor to welcome all of you as participants in this webinar. which is very important, and it is focused on one relatively new medical and social problem, but it is with increasing importance because of the aging of the population all over the world. And it increases, you know, that with aging, the risk of sarcopenia is increasing as well. I'm glad that the Faculty of Public Health and at the Medical University Sofia is co-organizer of this event. This is a great honor for us because the Faculty of Public Health is the structure in the university, which is focused on prevention and early detection of diseases and symptoms. And it is very important when sarcopenia is diagnosed early as possible and prevent as much as possible. So I think that all of us who are here at this webinar should combine our efforts in educating people how to live a healthy life, train them, participate in the early diagnosis of their diseases, and participate in the process of rehabilitation. So this is very important in order to keep our societies healthy with preserved workability and quality of life. This problem is very important for me as well as an expert in occupational health, because with aging, the workers lose their muscles, the quantity of their muscles, and this is related with the increased risk of occupational diseases and injuries as well. And also they lose, with the development of this sarcopenia, they lose much of their working ability. So it is very important to focus on such risky groups of workers as well. And I will repeat that it will be great if we combine our efforts in order to educate the people and the workers working hard activities, hard work, how to keep themselves in order to keep their quality of life as longer as possible. So I would like to congratulate all of you who are here, and I would like to wish success of this webinar, which hopefully will not be the last, but it will be a start of a series of webinars, and I will be glad if more participants from different areas, because this is an interdisciplinary area and problem, will join and combine their efforts in order to prevent this disease. Thank you very much and wish you success.
Thank you. Thank you, Professor Lyubomirova. Thank you for your kind words. Thank you for being with us tonight. It's a great honor also for sustainable abilities for our section in Greece. And we would like to continue now with the presentation from Professor Andrea Olaskoaga. Let me introduce her to say some words about her. Andrea was introduced to me from Melina Longoni, a colleague from Argentina, and I am very happy about that, because Andrea will give a very nice presentation about sarcopenia and hip fractures. Andrea is a physical medicine rehabilitation specialist, is the head of the Spine Rehabilitation and Osteoporosis Clinic at National Institute of Rehabilitation Luis Guillermo Ibarra in Mexico. So, Andrea, we are waiting now for your presentation, and my co-moderator Adonis will help me and put the video from Professor Olaskoaga. Adonis, please.
Hi to everyone. It is an honor for me to participate in this webinar. Thank you, Dr. Dionysiotis, for the invitation. I will be talking the next few minutes on sarcopenia and hip fractures. We'll go through this content. We're going to talk about world population aging and some data, then a little bit about sarcopenia and hip fractures and undernutrition and osteoporosis, and we're going to go through relation of sarcopenia and hip fractures and what's important and the impact on clinical outcomes. As we know, world population is aging. Here we can see the percentage of population aged 60 years or over by region, and this report from the UN in 2017 shows the estimates and then the projections for 2050. As you can see, 24% of the population now of Europe is over 60 years old, and this proportion is 21% for North America and 16% for Oceania. And in the case of Latin America and the Caribbean, this proportion is expected to increase to 26% by 2050. And if it is the fifth region with the highest proportion of older adults by now, it will be the third by this 2050. As you know, sarcopenia is defined as a muscle disease characterized by progressive and generalized decreased muscle strength and loss of muscle mass. Literature regarding sarcopenia now includes an increasing number of studies that show an association between newer consensus definition of sarcopenia and adverse health consequences, including functional decline, frailty, impaired quality of life, increased healthcare costs, obviously, and also mortality. But sarcopenia is also associated with osteoporosis and falls, and therefore patients with hip fracture are more likely to be sarcopenic. Aging disturbs the homeostasis of skeletal muscle, which requires balance between hypertrophy and regeneration through complex and not yet fully understood mechanisms and pathways. So as you can see in this slide, many observational studies reported a significant association between sarcopenia and these clinical outcomes in patients with hip fractures. Association between sarcopenia and mobility has been reported after 1 year, and many studies set outcomes also for mortality and activity daily living. And for example, Malafarina et al. Reported sarcopenia was a predictor of mortality at 7 years, and other researchers reported the association between sarcopenia and activity daily living at admission to a convalescent hospital and at the discharge from a rehabilitation hospital and after 3 months. And others reported association between sarcopenia and quality of life. And it has also been found that sarcopenia is related or influence hospital length of stay. In this study by Sousa et al. In 2015, sarcopenia was independently associated with longer hospital admissions, and this association was the strongest for patients aged 60 years old or over. And when compared with non-sarcopenic hip fracture patients, sarcopenic hip fracture patients have a significant risk of incomplete functional recovery. Overall, sarcopenia was found to be a significant independent predictor of postoperative clinical outcomes, and the diagnosis of sarcopenia is important to improve all these clinical outcomes you can see here. Information about patients' functional outcome is especially important, given that the rapid aging populations worldwide have resulted in this increasing attention from researchers and policymakers to aging-related syndromes, as all these are, and affecting patients' functioning, such as sarcopenia and frailty. So elderly individuals suffering from sarcopenia are over 3 times more likely to fall, regardless of age, sex, or comorbidities. After hip fracture, if the decline in muscle mass and function is not regained during the recovery, the risk for recurrence of fall-related fractures will only rise, and it might double or even more, according to the site of the index fracture. There are many recent studies that show that there is an increased risk of a hip fracture of 40 to 60% when a decrease in either muscle mass quantity or muscle mass quality is seen. And just let me remember here, we talk about muscle mass quantity when we are measuring cross-sectional area of muscle through MRI or CT, and we talk about muscle quality when we're measuring through ultrasound or X-ray attenuation. So sarcopenia is of importance for hip fracture patients because it puts them at risk for falls and fractures, but it also has an effect on outcomes. Here you can see these results from a study from Todd et al. This was a study performed in a really large sample of women with a mean age of 33 years old, and he studied previous fractures for 12 years before or previously the index fracture, and he among the results he shows this 13.7%. In the same study, the Swedish woman that were aged from 55 from 55 to 90 years old, and the proportions of women with a previous fracture are presented here by index and age, and in this dark shading indicates the proportion of women within that group who experienced a previous fracture before the index fracture. So this number, 28.6%, for example, of patients have experienced at least one previous fracture within the 12 years before the index fracture, and this increased with age, as you can see over the next circles in every fragility fracture. So approaches to defining sarcopenia remain controversial somehow, but although several groups have proposed ways to define the condition, as you can see here, there are different study groups, and with some varies in the definition, but particularly they varies in the criteria used, not only in the cutoff points, as you can see here, but also in the instrument measure each of the different elements included in these criteria. And the definition most cited today is the European Working Group on Sarcopenia in older people, and endorsed by the Asian Working Group on Sarcopenia, and they're both updated in 2019. And so this is the only definition they're endorsed, the European Working Group definition, endorsed by a variety of international scientific societies for clinical practice and research. So let me talk a little bit about bone. We all know it's a dynamic tissue that constantly remodels itself in response to mechanical stress and hormonal changes. And under normal conditions, bone resorption and formation are closely linked in time and space to maintain the integrity of the mass and the microarchitecture of the skeleton. And so this tissue also has the ability to adapt its structure and function in response to mechanical loading and forces and metabolic demands. And so peak bone mass is reached between the ages of 25 and 30, determined by all these multiple factors, mainly genetic, nutritional, physical activity. And so the balance of bone remodeling is maintained until the age of 40, and later, age and menopause in women are determining factors in the bone loss phase. So this loss of bone mineral density has been rated since many decades now. In postmenopausic women, the rate of loss, it's 5% a year, the first 5 years after menopause, and then 2 to 3% a year in the following years. For senile women, it goes from 0.6 to 2.1 percentage of loss a year, and in men, it goes from 1 to 2% of loss a year. And in the same way, if we study the loss of muscle mass and strength, we can see that the muscle mass has a rate of loss from 50 years old from 0.5 to 2% a year. And from 60 years, the strength diminishes or losses from 1.5 to 3%. But men and sedentary population has a higher rate of loss a year, and this prevalence can duplicate or double compared to women. And in the same way we can understand the changes of bone mass, we can study changes in muscle strength to lifespan. And as you can see in this study, where root muscular strength was measured in different ages, the peak almost duplicates for men compared to women, but the decline after from 50 to 60 years, it's really substantial. The better understanding of the behavior of these tissues throughout life allows assigning the objectives of a targeted intervention, started obviously by prevention, but also for treatment. So as the population is aging, osteoporosis and sarcopenia are experiencing a higher incidence, and we're observing higher mortality and morbidity associated to fragility fractures, especially hip fractures. And the incidence of hip fractures is expected to increase due to aging populations worldwide. And according to IOF, there were 1.6 million hip fractures in 2000, and the expected number for 2050 is from 4.5 to 6.3 million of hip fracture. And so we know that musculoskeletal diseases are considered a second contributing factor to the years of life with disability, explaining 21% of them. But and this figure shows like weekly physical activity according to age decade. I took this graphic as an evidence from the Greek population, but it's pretty similar in different studies. And as we can witness a rise in chronic illnesses associated to aging, we can also see in this different population that aging goes along with a higher sedentary and a lower active, moderate or systematic active lifestyle. This so-called dangerous duo, that also named as sarcosteoporosis, sarcopenia, and osteosarcopenia most frequently, is like in the search to define the most appropriate term, that the problem in addressing this phenotype arises from the traditional management of sarcopenia and osteoporosis separately. And maybe we can say that there is also lack of consensus on what to call it, but it has to be better defined and characterized in order to homologue research and understand more precise and directed interventions. So bone and muscle are integrated tissues with shared functions whose development and maintenance usually run in parallel. And while physical exercise can increase strength and muscle and bone mass, both are compromised with aging or in situations of disuse such as immobility or after a stroke. And there is a sophisticated regulation of the balance between the synthesis and degradation processes of both tissues, and to the alteration of which would lead to the development of osteoporosis or development of sarcopenia. So both genetic and environmental factors participate in this regulation, either through shared control mechanisms like endocrine or nervous system, or through bone-muscle intercommunication at the level of organs, like biomechanical signals of physical activity, or to cellular or even molecular, as you can see here, the myokines, cytokines, or growth factors. So hip fractures among the fragility fractures are the most devastating ones. According to this evidence, there's a reduced life expectancy with a mortality rate that goes from 8 to 36% according to different races, ages, and time after fracture. There's a reduced ability to function with approximately 10 to 20% of patients requiring long-term nursing home care according to different countries, cultures, and availability of these home care institutions. And from 40 to 70% are fully regain their pre-injury level of independence. So there are these reduced measures of muscle mass that may worsen the prognosis following a hip fracture, according to changes in quantity and quality of muscle. And besides its own clinical consequences, a hip fracture represents like hallmark of a systemic bone fragility with enhanced incidence and prevalence of fractures at other skeletal sites, as we already mentioned. So we're going to go through some hints of diagnosing sarcopenia in hip fracture patients. And so the diagnosis should start for the evaluation of risk factors, and I wanted to show them here in 3 different groups. The roles that are very important intrinsic factors that includes history of falls, age, gender, drugs, medical conditions, etc., extrinsic settings, slippery floors, uneven surfaces, etc. So these risk factors for sarcopenia, including diet, like low protein intake, body composition such as sarcopenic obesity, drugs like the use of ACE inhibitors, steroids, among others, lifestyle habits, and the risk factors for low bone mass and osteoporosis, which we already know. And so with all this, we have a higher risk for falls and a lower strength bone strength. And all these take us directly to a higher fracture risk. So when studying the risk factors for fracture, there are some tools such as FRAX that is a very useful and practical tool to determine the risk of fracture in 10 years, and well, with some of limitations that it does not accommodate all known risk factors such as falls or as biomechanical markers, and it lacks some details on some risk factors such as smoking, like the amount of smoking or the number of prior fractures. And so it's only important to take into account that it depends on the adequacy of epidemiological information and that cutoff points should be considered for each country. So now I want to mention a few considerations to take into account when diagnosing this sarcopenia in hip fracture patients. So first of all, DEXA. So even though DEXA is the primary imaging method to measure BMD, we know that diagnosis of osteoporosis in a patient with a fragility fracture does not require DEXA, because the only presence of a fragility fracture in the absence of another metabolic bone disorders, it's enough for the diagnosis. And in the other hand, to talk about sarcopenia, we would need to take into account risk factors for a suspicion of sarcopenia, and then measure muscle strength through grip strength, measure muscle mass with DEXA or alternatives such as BIAA, like bioimpedance, or CT or MRI when available, and physical performance, considering gait speed, time up and go, short physical performance battery. And so one important question in this is this feasible in a hip fracture patient? So evaluation of sarcopenia in hip fracture patients is difficult due to mobility problems and pain. And so previous studies reported two ways to diagnose sarcopenia. One is the combination of muscle strength and muscle mass, and another it's muscle mass alone. And there are some others also. But for measurement of muscle strength, the JAMR dynamometer is validated and widely used for measuring grip strength. But we can find certain difficulties if the patient has pain. Here, the JAMR dynamometer, if the patient has pain or cognitive impairment and he might not cooperate good enough, as for some senile patients. We also have these isokinetic machines that can also be used, but are complex and not so widely available and not so cheap. The gold standard for the muscle mass estimation is considered to be CT or MRI, but the higher cost difficult their use. So although DEXA and bioimpedance analysis are acceptable alternatives, we should not forget that there are different methods that can result in different outcomes, which means, for example, in the case of DEXA or BIA, are mostly used to evaluate muscle mass in patients with sarcopenia, but we should consider some factors that might modify the results in post-fracture or post-operative hip fracture patients. No? For example, the implantation of metal in the lower extremity measured by the BIA may overestimate the muscle mass of the operative lower extremity because of its methodological limitations, or when using DEXA, hip fracture may limit patient positioning. As you can see in this image, the patient in some brands needs to position with internal hip rotation, and sometimes IV intravenous solution can affect both DEXA and BIA results if you want to measure over time and make comparisons between inpatients and outpatients. So therefore, whether BIA is a suitable method for measuring muscle mass in patients with hip fracture is unclear, and DEXA is not always available or not feasible immediately after the hip fracture due to this positioning of the patient. And so the criteria for sarcopenia diagnosis are becoming standardized, but further research using standardized diagnostic criteria is necessary in patients with hip fracture. So there are some alternatives in diagnosis that are being run in hip fracture patients. Like as you can see in these two articles, they're studying some biomarkers for sarcopenia in women with hip fracture in a small size, and they concluded they detected some of them. And also this other article in very old patients, both articles are from last year, and so they didn't find any differences in very old patients, also with a median sample size. So here are these This is just a part of a table from Ainoware et al. Study that we can carefully see how different diagnosis criteria are used for sarcopenia in patients with hip fracture. And so this way we can also find very varied prevalences reported on each study as well as different outcomes. So the overall prevalence of sarcopenia is high in patients with fracture. It ranges from 11 to 76% for both sexes. We have rates of 17% in a Spanish study, 47% in a Japanese group patients, and up to 71% of prevalence in a study, all of them in elderly hip fracture patients. But we should also consider in which moment are these studies measuring all these different criteria, because postoperatively, we know that there's a diminishing of lean body mass in the first 2 months after admissions and so on, with mass and strength that can change through time and can also affect the criteria taken in account to talk about different prevalences. And as a conclusion, I just want to share these final thoughts. The prevalence of sarcopenia is very high, and sarcopenia is a significant predictor of adverse outcomes in patients with hip fractures. The diagnostic criteria of the updated European and Asian working group are mainly used for the diagnosis of sarcopenia, depending on the race of the patients. And the use of standardized diagnostic criteria has had a positive impact on the increase in sarcopenia research in patients with hip fracture, which may diminish heterogeneity in studies in the near future and facilitate research on interventions to treat both entities. And thank you very much for your attention.
Nice, beautiful. Very beautiful presentation. We have now 2 comprehensive talks about sarcopenia, and now it's the turn of Yagadis Chetri to make a commentary about them or about sarcopenia generally. Let me introduce Yagadis. Yagadis is a friend of mine. Yagadis Chetri is a geriatrician from Nepal. He got his fellowship in geriatrics from Gérondopole of Toulouse, France. Professor Bruno Velas, is the chief, the head in Gérondopole. And his postdoc is from Johns Hopkins in the USA. And he's also the president of Nepali Society and a very active person in the geriatric community and a friend of mine since many years. Since 2012-13 in San Servolo. We met each other in San Servolo in Italy, and we became friends.
Yes.
And now, Yagadis, the floor is yours to make your comments, to add something.
Thank you, Yanis. It's my pleasure to be here with you and during midnight in Nepal. And it's very good to be around fellow colleagues who are working in geriatrics and other areas of research in aging. Beautiful presentation by both Professor Meyer and Professor Olas Klaga. Yes, I agree that our world is aging and we are having more and more age-related problems like frailty, sarcopenia, and it is our duty as people who are working closely with older people to make things better for them. And for conditions like sarcopenia, I agree with Professor Meyer that lack of knowledge is a primary factor to diagnose sarcopenia, even among healthcare personnel. I mean, sarcopenia has a very high prevalence in older people, around 15 to 20% in most of the older people. And it's even higher in people with cardiovascular disease. And it's associated with very high risk of age-related negative outcomes like falls and hip fractures, like Professor Olas Klaga let us know now about the relation between sarcopenia and hip fractures. Yes, and I agree that the diagnosis of sarcopenia is mostly based around European Working Group diagnosis criteria, and currently the Asian Working Group as well. Mostly, according to this European Working Group criteria, low muscle strength, low muscle quantity or quality, and low physical performance. These are three main characteristics of sarcopenia. And if 1 and 2 are met as it's called sarcopenia, and if all of these three criteria are met, it's called severe sarcopenia. And yes, and although we have this very high prevalence of sarcopenia in older people, the treatments are usual. We don't have like a magic pill that will take away this condition from older people. Either we need to prevent, like our colleagues are saying, either we need to prevent this disease, this condition, or either we need to, for now, either we need to use exercise as the only option we have. Maybe some nutritional interventions as well, but these are limited in a few studies, and not every study has shown very same amount of same kind of results. So for now, I think we should exercise the only focus for this. And for people who are having hip fractures and sarcopenia, it's very highly prevalent in people who have hip fractures. And of course, this kind of fractures in people with sarcopenia are related. So the fault-related fractures in sarcopenic people is really high as a result of less muscle function and low bone mineral density. So basically, it's interconnected relation. As all of us we know, bone and muscles are connected, and as a process of aging, we have these conditions like inflammation, chronic inflammation, and people as we get older, we could be physically inactive, and we could be physically inactive, so we may have the acceleration of the aging process. But these are the interconnected things. And besides that, malnutrition is one of the biggest risk factor for both hip fractures, sarcopenia, osteosarcopenia, and this other lot of age-related conditions. So altogether, all of these things, they play together to make people sarcopenic or having low bone mineral density, and result make them weak, frail. As a result, it's a major cause of disability and like a poor quality of life, leading to poor health, poor aging process. So, and I agree that these kind of conditions should be aggressively targeted, and for people who are not only clinicians but who are researchers as well. They should focus on more strategies to reduce these conditions. So I think there are not a lot of things to comment on these two topics. It's very clear, this thing. But if we have some other questions for our Professor Olas Koga and Professor Meyer, I think I leave the floor open for questions. And Yanis could see that thing. Thank you.
Thank you, Yagadis. Professor Meyer, do you have anything to add, to comment on something? Do you want to discuss something at this moment about the presentations?
I think thank you for these great presentations. And I think there was a little bit of overlap, but that's very good actually in the education. I really would like to state again, as a clinician, I wouldn't say it's easy, but it's possible to implement diagnostics into the clinical care, that we actually measure muscle strength with a handheld dynamometer in clinical care. And if we can make the investment of buying, for example, a BIA, it is possible to measure muscle mass, and the entire diagnostic state takes around about 5 to 10 minutes. So you get a diagnosis within that time frame, and then you can start treatment, which is already available. So I would really urge everybody to try to implement, or to think about how you could implement the algorithms in your clinical work flow.
Okay, Professor Olascoaga, something to add?
Yeah, well, thank you for the presentation. I agree, but there was a bit overlap. And what I think it's what I would like to emphasize about the talk I gave, is that the diagnosis in hip fracture patients might be a bit more difficult or complicated. And I think if we start really doing what this Professor Meyer is saying, is to start somehow diagnosing and applying these different measurements to get more like familiar with these tools, and not only the tools, but also the idea of looking for and diagnosing sarcopenia in hip fracture patients, and also in other fragility fracture patients. I think we're going to start detailing more what are the most difficult considerations in this type of patients, particularly, as I was saying in my speech, is that the moment to measure muscle mass in an inpatient or in outpatient clinic, or if it's before the surgery or if it's after the surgery, and how all, I don't know, like IV medications and fluids, and how the position of the patient, and how can the patient really cooperate when there's maybe pain, or even though if the pain is controlled, how the patient can really cooperate for these measurements. I think there are already some publications about this, but I think in different type of patients, we're gonna get through a more experienced way to measure this, but also to make this more standardized in fracture patients, which maybe I think is one of the next difficulties in clinical research.
Yeah, right. Any other from the panel? Professor Daly, would you add something? Would you like something?
Look, no, I don't have too much to add, but I concur with what both Andreas said. Definitely, we need to try to have this integrated into clinical practice, really for us to have the greatest impact and the benefits in terms of management for our patients. So absolutely, I think the biggest challenge we've got is to educate other clinicians for it to be widely recognised that we need to consider muscle and bone jointly in both the diagnosis and then subsequently in the management.
Great point. I agree. I totally agree with this. I will put a question to all the panelists about the use of DEXA in the measurements. Do you believe that DEXA is currently the gold standard in the measurements of muscle mass in sarcopenia? First, I expect an answer from Professor Meyer.
So No, it depends on who you ask. If it's a clinician or a scientist, I would say. So I will now have the hat on as a clinician, and so then you could say the DEXA is better than the BIA. But if you look at academically, then still imaging techniques as the CT scan or MRI scan are the golden standard. So if you also validate different techniques, then these would be to validate it on not really the DEXA. However, as I said, I think it's most importantly now to implement at least the diagnostics already into clinical practice, and to diagnose a severe sarcopenia, and then measurement techniques like the BIA and DEXA, but also the BIA, are sufficient as a starting point.
Thank you. Thank you. Any other from the panel about this problem? Professor Arzuaga?
Yes, I would like to add that apart from which one is the best tool for this diagnosis, I think it is more important to think that, well, maybe in some countries there are not many densitometers, or they're not so available. So I think one of the most important things is to also, even though you should know what are the limitations of any tool, that it, at least I think BIA might be somehow easily or more available than densitometry. So I would say this is also a consideration in so many clinicians, because like if we talk that DEXA is the gold standard and you don't have DEXA in your community or in your clinic, you feel like somehow limited to make the diagnosis. And I think we should start to have more experience with different tools, and then knowing their limitations. I think that's important to consider.
Yes, however, this is not the case, Andrea, for Greece. Greece is a land full of densitometries.
No.
So densitometric devices.
Yes.
So we have no problem to measure it. But
No,
we need to search about it. We need to the awareness. We need to increase awareness to the rest of physicians to look at sarcopenia and osteosarcopenia. Otherwise, we lose these patients. They are passing through our eyes and nothing happens. So, Eleni Mumji, Dr. Eleni Mumji has a question to make. Please, Eleni.
Hello, I'm Eleni Mumji. I'm a rehabilitation specialist in Greece. What I would like to ask is, during this period of COVID disease, obviously due to the mobility and all these health problems caused by the COVID disease, I suppose that we have many elder people of movement. So did you notice any augmentation of awareness between the other physicians concerning the disease of osteosarcopenia during this period? Thank you.
Who will answer now? Yagadis?
I suppose all of the specialists from all the countries.
Yagadis, do you have an answer to this?
I didn't really, it was not clear to me. Could you repeat the question, please?
The question was about the people with the post-COVID syndrome. What's happening with all of this, with increased muscle loss and bone loss? Eleni, would you like again to express the question?
Yes, I mean that given the fact that COVID disease is a very, it provokes many problems, many health problems. First of all, it provokes a lot of immobility. So did you notice if the other physicians had in mind the disease of osteosarcopenia, given the fact that they treated patients who had to be immobilized and who had to suffer of other health problems because of COVID?
I totally agree with you that older people who may be at risk of COVID and who already have COVID definitely are at risk of immobility, and they have lost physical function. It's definitely they will have this even serious problems. But we did not conduct such studies here in our institution. I'm sure there were some papers recently published. They should have some answers on on this issue, I think so. But for quite frankly, I do not know which exactly has this answer. Maybe some other colleagues have answers to this.
We'll see. It's a difficult question. Professor Meyer?
Yeah. So as I'm working in the hospital system, I think it's a very relevant question, but I don't think that due to COVID, sarcopenia got lots of awareness. I think first the healthcare system has had to cope with having COVID and actually being able to treat all the patients, and either on COVID wards or non-COVID wards. But what I realized is that the nutrition got much attention at a certain point of time, because also having not the smell and not eating well really got the attention, at least in my hospital, in the hospital of my colleagues. So that really much more supplementation was prescribed, which is of course a very good one also as a treatment for sarcopenia, even if it's not being diagnosed at that point in time. So on COVID wards, I think we always had the discussion while writing the protocols, what can you actually do in terms of physical activity because you are in isolation, etc. But I think we already found good solutions on what kind of exercise we can do on COVID wards. And then on non-COVID wards, I think we had to also struggle with where to have the allied health interventions because of lack of resources at a certain time. So I think we could argue that, and we have a good argument, that please look for sarcopenia, especially if you have a devastating disease like COVID in older individuals. And a very easy one is already to get the nutritional factors to nourish the muscle. And I think, and I know that there are a lot of studies already showing muscle mass decline, especially in the rehab phase, and then the gain again if rehab was successful. So short summary, yes, muscle is very important in the COVID disease. I think we have a very good argument to have more attention. However, the implementation is there with not being better compared to other diseases yet.
Great. Any other from the panel wants to add something about it? No. We need to proceed because it's getting late. And it's getting more late in Nepal, I believe. So the next session, I would like to present you now the chairpersons, Eleni Mumji and Styliani Papacosta, two physical medicine rehabilitation colleagues from the geriatric section of Hellenic Physical Medicine Rehabilitation Society, together with me in the board of this section. And thank you for accepting the invitation, and thank you for being with us, and thank you for chairing this session.
So, hello again. Of course, it is a great honor for us to participate as panelists on such a webinar organized by the Medical University of Sofia, more even so to be given the opportunity to meet all these extraordinary specialists from all around the world. So I'm very happy to present Dr. Yannis Dionysiotis, who is in bone metabolism and geriatrics. If someone takes into account the thesis he has concluded. And he's currently working as a senior consultant at the National Physical Medicine and Rehabilitation here in Greece now. And we're all ears because he's going to present information about osteosarcopenia and whether it is worse than sarcopenia or osteoporosis. Dr. Dionysiotis, we're listening.
I'm waiting for Adonis to put on the video. Just a moment, please. Adonis, can you hear us? Thank you. Thank you.
Good evening. Good afternoon. I would like to thank the Medical University of Sofia for the kind invitation to present in this international webinar. I will start immediately with my presentation. Osteopenia and osteoporosis are leading to fractures, and we know that sarcopenia is leading to falls, and most fractures are happening due to falls. So all these entities are connected somehow. And beyond FRAX, which is the 10-year probability of fracture, it's time to consider sarcosteopenia, as Neil Binkley and Björn Bering said in 2009. They called for the attention to individuals who would be the carriers of a phenotype, which would be identified by the association between low bone mass and low muscle mass. And this combination could be expected to identify individuals as being as higher fracture risk they currently appreciated. The identification of this high risk group could lead to a non-pharmacologic and ultimately to use pharmacological treatments that enhance bone and muscle function. The term osteosarcopenia has been recently coined as a syndrome that combines the biological and clinical features of osteoporosis and sarcopenia. And this syndrome is associated with a high risk of adverse outcomes in older persons, predisposing them to frailty and disability. On the one part, we have the low BMD with osteopenia and osteoporosis. On the other part of the syndrome, we have sarcopenia, either low muscle mass and low muscle strength and or low physical performance. However, the difficulty in conceptualizing osteosarcopenia increased, and consequently, the variety of diagnostic criteria, which became one of the main challenges for the epidemiological studies and the clinical characterization of this patient, because we have all these societies having different definitions and different criteria for this syndrome. And what we know, because of these several definitions of sarcopenia, have resulted in differing prevalence estimates. This difference in prevalence may be attributed to variation in cut points for muscle mass, for muscle strength, for appendicular muscle mass, including the methods of correcting appendicular lean mass for head squared and body mass index. And only one definition till now, the new definition of European working group of sarcopenia older people, gave a T-score -1 as lower BMD for osteosarcopenia. And as you know, as you can see, here is the second definition for osteosarcopenia. Only this definition, in this definition, the prevalence is similar, either using BMD below -1 or BMD below -2.5. Coming now to the pathophysiology of osteosarcopenia, we know that there are common relationships between muscle and bone and interaction, common mechanisms, developmental mechanisms. We have the positive effect of pleiotropic genes on both muscle and bone, and the adverse early environment to muscle and bone with negative effect. Endocrine and hormones have an effect on muscle and bone, and we know that through the action of mechanostat, the muscle acts on bone, and also physical activity, vitamin D acts on both of them, and there are muscle-derived peptides with possible effects on bone, some positive and some negative effect. I would like now to introduce you Harold Frost, an US-American orthopedic surgeon. Frost dug up the mechanostat hypothesis and brought us the Frost mechanostat theory, a very basic theory in the field of muscle and bone, that says that if sufficient load is applied to bone, a threshold in the bone is reached and bone is synthesized. If muscle load is below a set point, if for instance muscle are immobilized or paralyzed, bone tissue is lost. Bone strength is regulated by maximal muscle forces according to this theory. And coming to the biochemical interaction of muscles and bone. We have the muscle who talks to the bone with his myokines, IGF-1, myostatin, osteoglycan, irisin, etc. But also now we know that bone is talking to muscle through the osteokines with IGF-1, sclerostin, osteocalcin, etc. And this nice proposed model of bone muscle crosstalk, this drawing depicts both the mechanical and the biochemical aspects of the bone muscle crosstalk. This larger cycle outside in the figure represents the organismal nutrition and lifestyle, and genetics, the influence. The two lower, smaller here cycles represent theories explaining bone muscle communication. The mechanical cycle here presents the established principle I told you before, that increased muscle load directly contributes to increased bone mass and vice versa. The biochemical cycle represents the growing body of evidence related to factors that are secreted from both bones and muscles. And here is the common area represents the concept that both mechanical forces and secreted factors could prime or sensitize receptors in both tissues for reciprocal activity. This central area is also influenced from genetics, nutrition, and lifestyles. And as you can see here in the left and right side of this figure, the interconnecting levels of organization reflect the influence of system biology on the interpretation and understanding of bone muscle crosstalk. And of course, we have also bone muscle interactions in vitamin D. Vitamin D has positive effects on bone mass and also positive effects on bone. What about now other biochemical parameters like parathyroid hormone? You have here a nice study showing that high parathyroid hormone levels are associated with osteosarcopenia in older individuals who have a history of falling. In this study, we had self-reported falls past 6 months and fractures past 5 years within each of these subgroups: osteoporosis, sarcopenia, osteosarcopenia, control groups, etc., were plotted, and whether the subject had PTH above or below 6.8 picomole per liter. Patients in this osteosarcopenia group had a higher prevalence of self-reported falls and fractures than those in the other 3 subgroups, and the present findings suggest a direct effect of high level of PTH on muscle mass and performance. And now we are coming to the developmental biology of muscle and bone. Following this concept of form follows function, bone and muscle biologically both share the same cell precursors known as mesenchymal stem cells. In addition, bone-muscle relationships include a local biochemical control combined with a complex system of humoral interactions. And their mass is determined by genetic background, cytokines, steroids, GF, W, and T, FGF, and embryogenesis. The determination in embryogenesis is by genetic factors and cytokines. In adolescents, by sex steroids and mechanical loads and forces exerted general control throughout life. But they have also differences, because we know that in bone we have a continuous bone remodeling. The process of remodeling is achieved through coordinated action of osteocytes, osteoclasts, and osteoblasts, and the rate and degree of coupling of bone formation to resorption during remodeling is regulated by endocrine factors, but also autocrine and paracrine. On the opposite, in muscle, amongst the most dominant factors controlling muscle size is myostatin, a member of a TGF superfamily, and myostatin negatively regulates skeletal muscle size. Close relationship, even before birth, between muscle and bone. with LMNA-related disorders, the laminopathies, which caused by the mutation of LMNA gene. Laminopathies are associated with a wide range of disease phenotypes, including neuromuscular, cardiac, etc. disorders. The most frequent diseases, however, associated with mutation in LMNA gene are characterized by skeletal and cardiac muscle involvement. For example, here progeria, for example, is Osteosarcopenia as a lipotoxic disease. This is a brand new concept from pioneer scientists in the field. This condition has been associated with fat accumulation in bone and muscles. This fat negatively impacts cell function and structure through secretion of free fatty acids and adipokines, a phenomenon called lipotoxicity. The fatty infiltration of muscle and bone is triggered by a very similar set of risk factors: aging, sedentarism, diabetes, neuromuscular disease, etc. Increasing levels of free fatty acids and adipokines in muscle and bone induce dysfunctional autophagy and apoptosis, which affects osteoblast differentiation and number, increases osteoclast differentiation and activation, and affects the number and activity of predominantly type 2 muscle fibers. But which is the phenotype of osteosarcopenic person? The phenotype, we can find a phenotype from this study, and the phenotype could be an old person, female person with some kind of depression and some peptic disease and some maternal hip fracture and hyperparathyroidism. This is a kind of phenotype for this osteosarcopenic person. But the true risk factors, we can see the risk factors, combining the factors from osteoporosis and sarcopenia. And I believe this audience is very experienced to understand which are these risk factors. I don't stay long in this. How can we diagnose osteosarcopenia? Can we use DEXA? Yes, we can use DEXA for the diagnosis. We can measure bone with DEXA, and we can measure appendicular muscle mass with DEXA. Using whole body DEXA, and using this algorithm, we can make a diagnosis. This figure shows a distribution of bone mineral density, T-score mainly, and appendicular lean mass of the investigated cohort in this study, and the cutoffs were set to separate osteoporosis from osteosarcopenia and osteosarcopenia phenotypes. So only osteosarcopenic adults showed a significant reduction in physical performance as a significant increased bone and significantly increased bone turnover, suggesting that the sarcopenic individuals are at a higher risk for further functional decline and fractures compared to sarcopenic and the rest cohort subjects. Can we use some biochemical measurements to identify, to screen, to find some persons who have osteosarcopenia? This is a very good kind of study, and this study, this strategic plan, how we can diagnose, how we can find the most cost-effective way in diagnostic rate versus cost per diagnosis or alternative screening strategies to identify and treat metabolic contributions for fall and fractures. We can use this kind of parameters to exclude also secondary causes: 25 vitamin D, calcium, PTH, serum testosterone, TSH, creatinine divided GFR. About prevention and management now, what we can do for prevention and healthy, we can recommend a healthy lifestyle. Good smoking cessation, alcohol restriction, physical activity, resistant exercise, but I don't say a lot of this. In this, vitamin D, calcium, we need levels to reach levels, particularly we need to supplement with vitamin D subjects with levels below 50 nanomole per liter, and we can use all pharmacological drugs, the non-pharmacological drugs for osteoporosis we know, and increase the protein intake. exercise is a drug. We know that we can. It has a particular dose, frequency, and so on, and we can use some kind of resistance training, endurance training, and low intensity inclusion training. But I need to stress this point that in old people we have the problem of anabolic resistance of muscle protein synthesis with aging because of many reasons, and we need to give increased amounts of protein because we need to overcome this anabolic resistance threshold in order to have gains from protein supplementation. And some years ago, together with Yagadis, Dr. Chadri, we published these recommendations, especially for rehabilitation of older people, and we recommend increasing protein intake to 1.2 grams per kilogram per day, which may improve muscle parameters. According to drugs, we have recently data. We have recent data from a publication with denosumab. Denosumab, which is a rank-like inhibitor, is commonly used as antiosteoreceptive for treatment of osteoporosis. A recent trial delivered. This trial lasted 3 years, 36 months. Delivered either denosumab or bisphosphonates to women with osteosarcopenia, and those treated with denosumab had increased appendicular limb mass and hand grip strength compared to those with bisphosphonates. No change was found in those with bisphosphonates. And another nice study about the effect of denosumab on force, muscle strength, and function. We have some, we've read here some positive results in some parameters, force functional scale, and the force efficacy, and the 4 square step test. And according to other drugs, there are drugs recommended for osteoporosis or for sarcopenia, but there is no drug at the moment recommended for osteosarcopenia. And allow me now to finish with the osteosarcopenia school. This concept was based on the work of physiatrist Dr. Eleftherios Bakas 20 years ago in the treatment of osteoporosis in patients using physical and rehabilitation methods. However, it remained as a theoretical concept and never used in clinical practice. Now it is modified in osteosarcopenia school, a spherical therapeutic process program which involves informing of the patients, training them, applying specific programs and activities, a long process. The intention is to increase the functional levels of independence and self-service of subjects that suffer from osteosarcopenia, to increase the active participation and not isolation from society, whose members they used to be in a creative way. And the medical intervention affects these vicious cycles, which is leading to disability because it has an enormous contribution. The best way to make this intervention successful is to informing the patient. Information should be more constructive and creational with the proper education of the subjects. First, we need a briefing, a clear briefing or a detailed, honest briefing without hints. We need to highlight the importance of the diagnostic approach. To the diagnosis also includes the advantage of the identification of the condition and emphasis on personal protection and injury prevention. The medical intervention of this briefing leads to active participation, bi-directional relations between the physician, the physio and the patient, and the problem recognition and awareness and smooth diagnosis acceptance. All these have result to decrease osteosarcopenia risk, to decrease fracture and fall risk, and increase in adult. Here I would like also to highlight the help from Konstantinos Prokopidis in these particular slides. Initial information affects patient's psychology, and therefore he is forced to make his responsibility, to take the responsibilities and to participate from the beginning in the program. This leads to a mutual trust, and the possibility of deformation of the body needs also to be explained clearly in the patient. This is how the patient knows now the causes, is explained the difficult some activities of daily living. Here is this triad: prevention, management, and education. Education and prevention. of falls. About education about the modification of bones mechanical strength, about this neurological condition that's happening with pharmacological preparations, with sleepiness, confusion, the walking instability, balance disorders. The educational targets should be understanding the new body mechanics, the activity analysis of new environment, the movement adjustments, increase of activity levels, performing at the use of assistive devices, and all this improve functionality, which is our point, the point. So we need to have a general program of principles in our exercise program. We start slow and moderate loads. Calm breathing and avoided breathing are suggested in the beginning. Breaks. Emphasis is placed on hydration. Before, during, and after exercise. This is how the program starts. On side gait, warm up, lifting legs from a sitting position. Then with using a chair, rubber bands, bottle of water, strengthen the muscles of the upper body. Repeats 2 to 3 rows, frequency 5 times a week in all exercises. Here with the bottles of water. Now here bending the knees, hip abduction, sitting and standing from a chair, bend of the knees again, toes and heels. There's some stretching, and I will finish with a couple of messages. We need to be careful with this syndrome. It's many times asymptomatic. It is diagnosed late and treatment starts after fractures. We are limiting our efforts only to treat osteoporosis. Is associated the syndrome with worse physical performance and falls in fracture history in community dwelling older adults. Very serious syndrome. The take-home message is the need for screening for the disease in our patients, making the necessary diagnostic tests, correcting possible secondary causes, giving instructions for exercise, nutrition, and drugs, and referring to special centers high-risk patients. And finally, you can submit always to the Journal of Frailty, Sarcopenia, and Falls. I have the privilege to be the co-editor-in-chief. I would like to acknowledge our editors, our other editors, chief editors, Professor Lyritis, Professor Skelton, Professor Charlotte Bodar, PhD Rizu, and Paris Lyritis, our publisher. Thank you for your attention.
Thank you, Mr. Dionysiotis. It was a very nice presentation. It was a pleasant and interesting way to see how bone and muscle talks to the other, and how form follows function, and how we can understand the pathophysiology, the diagnostic criteria, and how we can decrease the risk from osteosarcopenia. It is an honor for me to present Professor Robin Daly. Professor Daly works in Deakin University as a professor and chair of exercise and aging, and he also was a professor, scientist, director of research within the Department of Medicine at Western Healthy at the University of Melbourne. He will introduce us one of the most effective interventions that we have in order to be preventive and therapeutic against osteosarcopenia. He will introduce us the exercises in elderly with osteosarcopenia. Professor Robin Daly, welcome.
Hello, everyone, and thank you for joining me for my presentation on exercise in the elderly with osteosarcopenia. My name is Rob Daly, and I'm the Professor and Chair of Exercise and Ageing within the Institute for Physical Activity and Nutrition at Deakin here in Melbourne, Australia. So I'd like to take this opportunity to thank Giannis and his colleagues for the invitation for myself and our society to be part of this symposium or webinar. So to begin with, I'd like to start with a video just highlighting an elderly woman and a challenge of climbing a flight of stairs. And for me, it's clearly she's got impaired function, probably got low muscle mass, and may well have osteopenia or osteoporosis. And so the challenge we're faced with is what type of exercise do we prescribe this particular person? So when I think of exercise prescription for osteosarcopenia, these are my key goals that I would recommend that we're trying to achieve. First, obviously trying to maintain or improve bone density, but particularly at the localised regions of bone weakness, which we know are prone to fracture, such as the hip, the spine and the wrist. Clearly, we want to maintain or improve muscle mass, strength, power to optimise function, enhance independence and reduce the risk of falls. And so what we really need is a program that's safe, that's multimodal, progressive, targeted to the specific needs of the individual, obviously individualised, and is readily accessible to encourage long-term adherence. We also need to consider various nutritional aspects as well, which I won't really discuss in my presentation today. So I've borrowed this slide or adapted it from some recent guidelines put out by the National Osteoporosis Society from the UK, where there were exercise recommendations for osteoporosis, and I've adapted these for osteosarcopenia. And they're basically three pillars that should form an exercise program. First, strong for bone and muscle strength, being steady to reduce falls, and straight with the focus on reducing the risk of vertebral fractures, improving posture and alleviating pain for those that may have vertebral fractures. And I think this really holds stead to what we should be thinking about when we're prescribing exercise for people with osteosarcopenia. And what was really nice about these guidelines is they came up with this algorithm in terms of what might be an approach to prescribe exercise. And so for people with osteopenia or osteoporosis or sarcopenia, the first recommendation was to determine whether they were frail or at risk of falling or unsteady on their feet. And if that was the case, they recommended they follow a steady or a sort of a balance and gait type exercise program, which I'll talk about in this presentation. Once they maintain or improve their mobility, they can then progress to a strong program, which might include muscle or focus on muscle mass and strength and weight-bearing exercises to improve bone strength. Similarly, if you have a person who has back pain or vertebral symptoms, the initial emphasis would be on the straight program, which is really focusing on postural, back muscle, endurance and strength. And once they improve those aspects, they can then progress to either the steady or the strong program. So what does the evidence actually tell us around the different types of exercise? Well, we know that resistance training is very effective, particularly with regard to improving muscle strength and muscle mass. And most of the guidelines would suggest that around 2 sessions per week of progressive and periodised training at a moderate to high intensity really results in the greatest benefits. But it's important to note that there is considerable heterogeneity with regard to the effects of progressive resistance training on both the response to bone mineral density as well as physical function. And this is perhaps not surprising if you look at the various studies which have perhaps failed to observe some benefits for these parameters. And from what we often observe, we see programs like this. We see programs where people are seated, they're doing light weights, there's very little progression. And this is really a characteristic of many ineffective programs. They're typically short duration, have a poor or inadequate training dose. Importantly, they lack progressive overload, and probably the most important factor is they lack exercise specificity. So they don't actually target the regions which are really trying to improve, whether it's hip bone density or muscle function. And another characteristic is they're often associated with poor compliance, or they don't include some sort of supervision, which is related to a lack of progressive overload. So just to highlight the importance of exercise specificity, here's a resistance training program which was done in men. It was only a short-term study, but they were really after trying to determine whether there are specific types of exercise which might improve bone density. And so they took some CT scans here and did this voxel-based analysis where they were able to look at the sort of voxel by voxel, like pixel by pixel, changes in bone density at different sites through either a hip abduction program, a squat or lift deadlift program, or the combination. And what you can see from the illustrations of the hip, where there's a coloured region, this is where the greatest change occurred in response to the intervention. So for the hip abduction exercise, the most changes in BMD occurred at the trochanter, whereas the squat and the deadlift tend to occur at the inferior part of the femoral neck. And you may ask, why is that important? Well, there's some fascinating data which is shown from CT scans of hip fracture and non-hip fracture patients where there's areas of weakness specifically within the femoral neck. And so we know that the femoral neck region's superior part is extremely thin. And when you fall sidewards onto your trochanter, or the side of the hip, a lot of the strain is placed on this superior part of the femoral neck. And we know from these imaging studies that this yellow region within the superior part of the femoral neck is a focal area weakness, which is characteristic of people with a hip fracture. And so the challenge is, how can we design exercise programs to really target these areas of focal weakness? Now, we've also gained some very useful information from various modelling type studies which have looked at the effects of different types of exercise on strain patterns throughout the femoral neck or the lumbar spine. So in this particular example, they looked at different types of exercise, including walking at different speeds, running, hopping, and resistance training. And they developed these colour contour sort of mapping of the bone, which shows the tensile and the compressive strains. And what they found, and perhaps not expected, was that the hopping type exercises did result in increased strain in both the superior and inferior part of the femoral neck. And interestingly, even brisk walking did result in some benefits at these sites, but normal walking, slow-speed walking really had no benefit, which is consistent with the literature that walking really has very little effect on bone health, unless it's hill walking or, in this case, brisk walking. But what surprised me the most from this study was if you look at the effects of strain, the various strains throughout the femoral neck from resistance training, it didn't really load the femoral neck region, which is perhaps not surprising because a lot of the muscle attachment sites are not on the actual femoral neck. But it highlights that we need very specific training if we want to improve specific regions throughout the femur. So here's one such study where they were able to demonstrate regional specific effects from exercise. And what they did was very short bouts of weight-bearing impact exercise. And we know that impact exercise is particularly effective for improving hip bone mineral density. And in this study, they asked the men to simply jump, do 50 jumps on one leg every single day, and their other leg served as the control leg. And what they did, they took CT scans again, and they developed these sort of colour contour maps. And what it illustrates is that in specific regions of the femoral neck, they were able to get gains in bone density of 3 to 7% in cortical density and 5 to 12% in trabecular bone density. Now, these are far greater than the typical 1 to 2 or 3% changes which we typically see with a DEXA scan in response to exercise. So perhaps many of our exercise programs are really underestimating the true benefits that we see in bone mineral density. But this just highlights you can get some specific gains at targeted regions. We're also moving along in our exercise prescription for weight-bearing exercises by quantifying the ground reaction forces of different activities. And so we're able to look at the loads these forces are placing on the bones and how quickly these loads are applied. And this is quite helpful because it enables us to sort of categorise loads into sort of low, moderate or high. And so when we're prescribing exercise programs, say for a high-risk person, we might consider sort of side lunges or walk-in type activities to start off with and progress to some of the moderate impact loading activities. In terms of where you're probably going to get your best benefit in terms of bone, is probably from multimodal programs. Now, again, this is a series of meta-analysis which highlights that probably multimodal programs overall result in the biggest benefits. And multimodal really means a combination of resistance training with weight-bearing impact exercise. So if you see the graph here on the resistance training alone, you can see for the changes in bone mineral density in response to the exercise intervention, there is considerable heterogeneity. Many of the studies didn't result in a positive effect. And again, it's probably because they were not targeted specific and didn't have enough overload to result in changes at this site. But if you combine resistance training with weight-bearing exercise, we get a much more consistent benefit. So we, like many others, have done multimodal exercise programs, and we did this program a number of years ago called Osteosarcopenia Strong Bones for Life. So it was very much a research translation type project. It was an 18-month randomised controlled trial run in community-based centres. Participants were asked to train 3 days per week. There were about 45 to 60-minute sessions in small groups to enhance social interaction. And many of the sessions were supervised by qualified exercise trainers. And we spent considerable time actually designing the exercise program, developing all these brochures, which included videos and examples of how to do exercises, which we thought were very targeted and specific to optimize bone mineral density, muscle mass, strength, and function. And so the program was very periodized and structured. So it gave them periods of rest and periods of high intensity. And the one interesting element or key element was we did both traditional and high velocity resistance training, which I'll talk about a little bit later. But essentially the program included 6 or so resistance exercises, and interspersed between the resistance exercises were 2 to 3 impact type exercises. And then they did a series of challenging balance and mobility exercises. And so the program was really quite successful in terms of its effects, not only on bone mineral density, but in benefits on bone, muscle strength, various measures of physical function, which you can see illustrated in the graphs, with the exercise group being the purple, and these showing the percentage changes over the 18-month period. Now, just to highlight that the blue region represents the 12-month intervention, which was very highly supervised and structured. And the white translational region was when we sort of, as researchers, decreased our level of support from the trainers, and we left them to try to deliver it without, intensive supervision. Now, what is also interesting from this study was that the adherence was around about 60% or so, which means they trained on average 2 out of 3 days, which is consistent with other literature, which suggests that multimodal exercise programs completed twice weekly, can have some musculoskeletal benefits. Now, in terms of people with osteosarcopenia, there's actually been very few well-controlled or well-conducted randomised controlled trials, but Kemmler and his colleagues from Germany have conducted this nice study in osteosarcopenic men who are aged 73 to 91 years, and it was an 18-month RCT with a 6-month detraining follow-up. And what they prescribed was largely high-intensity resistance training, and they had remarkable adherence to the program, 95%. And the program was very periodized and structured, and with a strong emphasis on high-intensity effort as well as high-velocity training, and people were asked to train twice a week. Now, I should just point out that everyone was given advice on nutritional supplements or tried to increase their protein intake, their calcium and vitamin D. But what you can clearly see was that for muscle mass and strength, they got substantial benefits with the exercise program. But once they stopped the training, shown in the red regions, the benefits start to decrease relatively rapidly. Similarly, you can see they got some increases in lumbar spine bone mineral density, and at the hip, it largely maintained hip density, bone density, whereas the controls had a decrease. So obviously, for some patients, we can't prescribe a high-intensity impact exercise program or even high-intensity resistance training to commence with. So we need to be careful what we prescribe for high-risk groups. And so for some people, maybe those with previous vertebral fractures or frailty or injurious falls, we actually minimise or reduce the weight-bearing impact exercises and focus on body weight and functional activities. Now, you'll note in these pictures in many of our programs, what we try to do is, if possible, do the exercises in a standing position rather than being seated, where they're going to really get no functional benefits. Other key elements for this high-risk group are, start with unloaded exercises, and then you might progress from seated to standing if they've got functional impairments. We certainly teach them how to transition in and out of exercises to avoid unnecessary movements which might increase the risk of fracture, such as reaching forward with a long lever arm, which can be place extra strain on the spine. And then for a key element, which comes down to the spine caring approach, is that we very much focus on targeting back muscle strength and endurance, because remember, the back muscles are postural muscles, and so it's important not just to focus on the strength but their endurance as well. And clearly we focus on teaching safe lifting techniques and moving techniques, thinking straight, thinking about bending the knees when lifting objects and so forth. Now, just to highlight that anyone can do exercise, here was a fantastic study which was looked at the effects of a multimodal exercise people who were acutely hospitalised, and these were in very elderly patients, mean age 78 years, and they were in hospital for an average 5 days.
And they did 2 daily exercise sessions, one in the morning and the evening, for about 20 minutes. And it consisted of resistance training, focusing or with an emphasis on high-speed movements, as well as challenging balance and gait retraining. And what they looked at as their outcome was this short physical performance battery score. And we know that if you have an improvement of 1 point, that's really clinically significant. After a median of 5 days, they got an improvement of 2.4 points. So this really just highlights that for people that may be detrained in this particular sort of example, you can get some drastic improvements quickly in muscle outcomes. And so just to highlight a summary of the guidelines for strong and straight, this emphasis on weight-bearing exercise, you don't need many impacts. You may only need 50 impacts on most days of the week. You can incorporate a range of moderate intensity activities, even sporting types activities for those that can tolerate it. But it's important to complement that with some, muscle strengthening exercises, probably at least twice a week, and, make them relatively moderate to high intensity and progressive over time. So what about people at risk of falls? Now, some types of exercise programs are more effective than others. And what do we prescribe for this high-risk group? So again, if you go back to the NOS guidelines, their emphasis here is on, a steady type program, which is really balanced gait and muscle strengthening to a certain extent. And so we know that not all falls prevention programs are effective. And this is a fantastic Cochrane review of the effectiveness of different types of exercise. And what we see is that on average, you can get about a 20 to 50% reduction in the risk of falls or the rate of falls for different types of exercise programs. But the most effective ones are those that include some sort of step-in training with challenging balance and functional activities. Interestingly, resistance training and general physical activity, including walking, was not effective. And this is really perhaps not that surprising, which I'll touch upon in a minute. But just to give you an illustration of what is challenging balance and step-in exercises, here's some illustrations from a trial we did called the PACEIT trial, where we introduced challenging balance, step-in and dual task activities into elderly people in retirement villages. And we developed all these resources once again and progressions of exercises that people could undertake once they were able to master a given exercise. And you can see we can start with seated activities to standing and very much try to progress to the functional balance and mobility activities. And so when we're thinking about falls prevention programs, we need to think why people fall over. And so if you look at this study, which looked at the most frequent cause of falling, loss of balance, slips or trips, or tripping over an obstacle were the main causes. But do our exercise programs really target these key risk factors? And so coming back to resistance training, why it might not always work. Traditionally, our resistance training is done like this, seated on a machine in a slow and controlled movement, yet we don't fall over slowly. This is not targeting really a slip or a trip, and targeting sort of maximal muscle strength. And so we know as we get older, we lose our muscle mass, we lose our muscle strength. But what people sort of ignore is that our muscle power, our ability to produce force quickly, our ability to move our leg quickly in response to some sort of perturbation is much more declined than either mass or strength. And so we really should be focusing on trying to optimize power, train to improve movement speed. And there's some really nice work showing that high velocity power training, which means you do the concentric phase rapidly, can result in some greater functional benefits than traditional resistance training. And you can even do a lighter load resistance training. So I'd say at 40% of your max versus a heavy load, and you can get similar benefits. And so there are some real clinically meaningful improvements from doing high velocity resistance training. And here's a fascinating study in which they were really looking at the effects of high velocity training on older person's ability to put their foot on the brake quickly in response to a stop sign or a signal. And what they actually found was quite remarkable. So they had one group do high speed training, they had one group do slow speed training, and they had the control group. And here's a little setup they rigged up, so like a car seat with a brake. And you can see that those that did the high-speed training had a much greater improvement in their braking speed, equivalent to 73 metres, which is quite remarkable and highlights the importance of specificity of training. And so, again, we have also done, recently completed a large trial, which we not only focused on functional power training, are trying to move quickly, but we also introduced the dual task element to many of our exercises. We know many people fall over because they can't dual task, they can't multitask, they can't do two things together, such as walking the dog and trying to talk to your partner. And that's where we often see people trip or slip over. And so we did this last trial in community, in retirement villages, where we introduced these functional power and strength activities, the challenging balance and the dual task. And what we saw was around about a 30% reduction in falls, which was just not significant, but a 70% reduction in the risk of injurious falls. And we saw improvements in various measures of function. So it does work. And finally, one of the challenges we're faced with many of our exercise programs is that people have to go to gyms or go to a hall or go somewhere to do the exercise. So we've been exploring this this option of exercise prescription anywhere, anytime, delivered by exercise professionals. And we ran this small pilot study looking at the role of technology or this PhysiTrack platform, where as an exercise trainer, we prescribe exercise to the person via their iPad, their phone, their computer, whatever it might be. And it's evidence-based, and we're able to monitor it remotely. And so we did this study where we only had 20 people. We gave them an iPad, or they already had an iPad, and the exercise trainer prescribed an exercise. The people were sent their exercise program, which gave them a narrated video of how to do the actual exercise. And then and how many reps and how many sets they should do. Then after, when they completed the exercise, they rated how difficult it was, or if there was any level of pain or discomfort. And once they completed that information then was sent straight back to the trainer, and we could monitor the program. If the person experienced pain, we could change the exercise straight away. We could do a telehealth session or a video conference with the person. And so what we found overall, that the program, there was 80% adherence to all the exercise programs, to the exercise training, which was done 3 times per week. And we're able to improve their overall physical activity levels, and we got small improvements in their function, although that was not really the main aim. There was very few adverse events, and the usability rated by these older people was very high. So we think this is certainly an approach, and we're exploring it with another trial, a much larger trial for falls and fracture prevention in the next few years. So my take-home message really is that exercise is medicine, but it must be appropriately prescribed. And for the optimal benefits for bone and muscle, we need to think carefully about the dose, the type, how it should be prescribed, are there any potential interactions or side effects, and how can we enhance adherence? Secondly, for osteosarcopenia, multimodal programs are clearly most beneficial, and that includes resistance with weight-bearing impact exercise, if possible, and challenging balance and mobility programs. But importantly, they must be targeted and progressive programs. And finally, one of our biggest challenges, how do we maintain long-term adherence? And so for people, older people and all those with sarcopenia, we need to move away from don't do type activities to how can we do the activities? We want to encourage more, not less. So on that, I thank you for for listening. I thank you for your time, and I'll be happy to take any questions during the panel discussion.
Doctor, thank you very much, Professor. Dr. Jakatic Kertri, sorry if I do not pronounce right your name. Can you hear us? Would you like to comment what you have heard?
Yes, I would make my comment very short. I agree with Dr. Yanni and Dr. Devi. But about sarcopenia, concept.
I cannot hear you clearly. I don't know if the others can.
Can you hear me, Yanni?
Yes, we can hear you. May you can speak a little bit louder.
Mm-hmm.
Yeah, okay. Thank you, Yanni, for
much better.
For giving us the overview on osteosarcopenia. And I agree, it's a muscle-bone interaction like we've been talking about the whole webinar. And thank you, Dr. Daddy, for your wonderful presentation on the exercise, role of exercise on osteosarcopenia. Yeah, I don't want to make a lot of big comments, and I think it's very clear that exercise is the only tool to get people functioning and keep them moving either they have sarcopenia, they have osteosarcopenia, whatever physical limitation they have. I would like to ask a small question to Dr. Daddy, that how do these people who have osteosarcopenia get to you? For example, while I was in Toulouse, they had those friendly clinics and memory clinics, and people who had these conditions, if they go to a GP, the GP would prescribe them to go to such clinics. How about in Australia? How do you, the older people get to you so they could get proper intervention from very specialized personnel?
Look, thank you. That's a good question. I guess we're quite fortunate here in Australia is that we have what we call accredited exercise physiologists, which are basically sort of similar to physiotherapists, but they're actually accredited to prescribe exercise for people with chronic conditions. And they're part of the Medicare system here in Australia, where a doctor under various healthcare plans can actually refer their patients onto an exercise physiologist who will then do an assessment and then write up an exercise program. Now, at present, they get 5 Medicare rebatable sessions. So it's basically free, more or less, to the patient. Obviously, that's probably not enough, really, but it's a good starting point. And sometimes they start with the exercise physiologist and then are referred to, let's say, an exercise trainer who can then undertake the program. But the exercise physiologist has the expertise to manage these people with chronic disease. So I'm not sure many other people or other countries around the world have these accredited exercise physiologists, but it's a relatively young area still, and many physicians, clinicians, other healthcare professionals are not so well aware of exercise physiologists and their role, and they think that perhaps there may be a standard personal trainer, you know, who might have done a 12-week course, but it's certainly gaining more and more recognition, or the profession is gaining more and more recognition, and now they're starting to get integrated into allied health teams. And so we see exercise physiologists now integrated into hospital settings, and they, as a result, people in hospital can get referred onto their exercise physiologist to prescribe programs as well. So that's sort of the approach, how we might get to see these type of people.
That's very, very fantastic. I mean, I think it's not in every corner of the world where these are interconnected, you know. But it's very good to see that Australia is working very fast on this. Yanis, would you like to add something?
Eleni, do you have any questions for Professor Daly?
Actually, I found amazing the fact that you can prescribe exercise so in such a concrete way. Because actually in Greece, we have just started prescribing exercise, and I don't think we're very concrete yet. However, I like a lot the fact with this application that you wanted to give the opportunity to the elderly via an iPad to do exercise all by themselves. Have you tried to do any program of exercising, like exercising via Skype or via Viber or via another platform, elder people?
You broke up a little bit in your question, but I think, was the question around how you prescribe exercise using different technology?
No, I wanted to know if you have tried to give instructions for exercise via telematically.
Yes, okay, sure. Yes, look, we have, and we do a couple of different approaches. So the approach that we did, or the example I gave right at the end there, is really quite unique. So what we typically do is we do a telehealth session with the person initially without going to exercise, or our exercise physiologist actually goes to the person's home and makes sure that their home setting is set up okay, shows them how to use their iPad or their phone or whatever it might be. Because when we actually prescribe the exercise to the person, it's essentially, like I said, a narrated video, which is detailed instruction and an example of the person doing the exercise. And so they essentially just watch the video and it gives them instructions in exactly how to do it. And then they do the exercise and then they can rate how difficult it is. Now, at the same time, we can also do a telehealth session simultaneously. So we can watch them actually do their exercise while they're doing it after they view it. So there's different approaches. And the other approach we're starting to explore is almost like a group Zoom type exercise session as well. Because again, they lose the social interaction obviously when they're doing it by themselves at home, and that's not our preference. We actually don't want them to do that. But you know what we found with a lot of our programs is that many people heard about the program and how it was effective, yet they lived 1,000 kilometres away from us and said, "How can I get your program?" And so we're able to, often we will say this as well, we'll say, here's the program, we send it to them and all the videos and how to do it. And then they still might go to their gym or community centre and do the program and get some extra instructions. But it's just giving them the evidence-based program to say this is what it should look like and this is how you could do it. You can do it either at home, you can do it in the gym, you can do whatever you like. So there's sort of different approaches that we can use. But again, we're sort of fortunate because we've got these exercise physiologists who can do their telehealth sessions. They can go to the person's home. They can prescribe it over the phone and that sort of thing. So we're still learning a little bit, and it's not perfect, but I guess it's just an approach for us to reach out to anyone that really might be interested in sort of a good quality program for their condition.
Rob, thank you very much, and thank you for bringing up this word power and muscle strength, because many physicians do not understand the difference. But you explain quite nicely with programs the power and the strength. What's the difference in the program? How you prescribe that? Thank you very much for that. And thank you for all these programs you are running there in Australia, and your publications are quite very nice. And I found very many similarities with our Osteosarcopenia school in the program. It's not exactly, but there are some similar points in our programs, and we may cooperate or collaborate in the future if you want. And now I would like to ask the chairpersons, Eleni and Styliani, do you have any other questions for the panelists, or should we move because it's getting late in Nepal?
Actually, Professor Mayer has a question from what I can say.
Okay.
One final question. I was really intrigued by the hopping and the bone mineral density. Could you advise us, Rob, how we could integrate more hopping in our daily life activities without getting lots of laughter in the street?
Yes, look, it's an interesting question. And to be honest, what we find in a lot of our programs for older people is they don't particularly enjoy the hopping weight bearing exercises. And so what we have to do historically is introduce our muscle strengthening exercises first of all. And then it's not all of them will progress to hopping, but the key point, I guess, with the hopping or the weight bearing exercise is you don't actually need many. And so I would encourage you, Andrea, every time you make a coffee, do 10 jumps or hops, and then you might do that. If you have 3 coffees per day, you're doing 30 jumps or hops, sort of thing. So that's how you can integrate it into your everyday life. So every time you have a coffee, everyone, or a tea, do your hops or jumps.
Oh, great. So now I can't see anybody from University of Sofia in the panelists. Yagadis wants to add something.
Yes, he has a question.
Yes.
Yeah. I have a question for Yannis. Could you please elaborate a little bit on your Osteosarcopenia school? I'm quite interested what exactly it is. Could you elaborate a little bit on it?
Yagadis, I didn't listen well the last few words of your questions.
Elaborate on the Osteosarcopenia school you mentioned earlier in your slide.
Yeah. It's a modified concept. It's a modified concept now. The concept was actually born 20 years ago from Dr. Bacchus, and now I have modified to Osteosarcopenia. I added some content, and I brought it in the clinical praxis, and I presented it a little bit quickly, but we will publish some data from these studies and from this exercise program. And at this point, I would like to share to you that you can send me your extended abstracts of your presentations and your commentary, Yagadis, and I will submit all of this as kind of proceedings in the Journal of Frailty, Sarcopenia and Falls. I will cover the expenses of any probable publication, don't worry about it, but you feel free to send me your abstracts in order to make some kind of proceedings of these with your names from this webinar. I believe it is a good idea to continue to collaborate and to learn more about these entities, sarcopenia or frailty maybe in the future, we'll see. Are you okay with this?
Yes, I'm fine. Thank you.
So now we are coming to end.
Dr. Yanis, sorry. I really have to make this comment. It comes from your co-host, actually, Dr. Kodaxakis. Well, with all this Greek dancing, all the Greeks, we have to have strong hips.
Yes, unfortunately
because
not.
there's a lot of hopping in Greek dancing, huh?
That was before COVID.
Yeah, right. So it's getting late in Nepal. Again, I repeat again. Good morning, Rob, in Australia. So, Andrea, have a nice evening. Professor Meyer, thank you for your participation. And Lenny and Styliani, thank you all. Yagadis,
We thank
Adonios, Adonis, thank you for your help. Here is Adonis, say hello. Thank you for your technical help with all your videos. Dr. Kodaxakis is working in the military hospital in Athens. He's also a physiatrist. Thank you all for your participation in this webinar from Medical University of Sofia under the auspices of Sustain Our Abilities, and have a nice day. Bye-bye. So bye-bye. Thank you all. Bye-bye. Thank you.
Bye.
Bye-bye.